We are going to discuss INI Common Entrance Test surgery questions of November. The first question is, what is Tilak sign? What do you mean by Tilak sign? So for this you should know what is Tilak's triad. This is a direct line from Bayesian law. Please understand Tilak's triad is a triad given for mesenteric cyst. This is abdominal cavity. This is the root of mesentery which is 15 centimeter in length, and this gives the mesentery like this, through to which all the small bowel is attached like this, to which the small bowel 6 meter is attached to this 15 centimeter of root of mesentery, 6 meter of small bowel is attached. If you get a cyst in this mesentery like this, if you get a cyst in the mesentery like this, there are three findings in. Number one, central dullness. Number two, zone of resonance around. So because of the fluid containing thing, there will be central dullness surrounded by zone of resonance. And number three is known as Tilak sign. What is Tilak sign means? I can now, in this condition, I can now move the cyst like this or like this. Which way can I move the cyst? You can see I can move the cyst perpendicular to the mesentery only. I cannot move it sideways, but if this is the root of mesentery, I can move it perpendicular to the mesentery. So that is known as Tilak sign. Tilak sign is movement of the cyst perpendicular to the mesentery is known as Tilak sign. Okay, mass is mobile only in plane perpendicular to the mesentery. That is, this is the root of mesentery, so the mass can be mobile in this direction only. This is a direct line from Bayesian law. So please don't forget mesenteric cyst Tilak's triad. So there's a central zone of dullness, zone of resonance around, and movement perpendicular to the mesentery is possible. So this is the first question, very simple question, directly taken from Bailey. So again the next simple question, 25-year female presents with history of progressive dysphagia for solids and liquids. Okay, barium swallow was done. The investigation shows this finding. What is this? You all know very well, this is a bird's beak appearance. Okay, this is a very simple bird's beak appearance you are seeing in a barium swallow. But this is Achalasia cardia. But Achalasia cardia, the gold standard investigation is not barium swallow. We have to do 24 hours pH monitoring is for GRD, okay, not for Achalasia. So this is Achalasia. For Achalasia cardia, the gold standard investigation is high resolution manometry. We should also do endoscopy to rule out. We want to do endoscopy to rule out other problems like pseudoachalasia causes like cancer in the OG junction or any stricture in the lower end of esophagus. All those things we have to look for in these cases. So that is very important for these cases. Okay. So we have to look for stricture and a tumor in the lower border. That is very important. So this is essential point you should not forget in this case. Okay. So endoscopy with esophageal manometry is essential for diagnosing a Achalasia cardia. So please don't forget, barium is showing you bird's beak appearance. Manometry is the gold standard. Endoscopy must also be performed in all suspected cases to rule out G junction tumor, strictures or neuropathy. All these things should be ruled out in this case. So please don't forget, the answer here is endoscopy plus esophageal manometry. So third question is again a repeat Aiims question. So Aiims, since Aiims is taking the INI Common Entrance Test pattern questions, so you should be knowing very well about the old Aiims questions also. So this is a very commonly asked Aiims question. So Q SOFA score. Q SOFA score is given by a mnemonic Royal Challengers Bangalore, RCB, remember like that. So respiratory rate, confused status and blood pressure, systolic blood pressure. These are the three things taken into account. So what are the things you should take in account is respiratory rate, blood pressure and confused state is nothing but a CNS feature. So answer here is A, B and C. WBC count is not a component in quick sequential organ failure assessment score. This is known as sequential organ failure assessment score. Please don't forget, this is a repeat MCQ for your exams. So sequential score Q SOFA is asked more than 2 times in various exams. So please be thorough with it. This is again also taken from Sabiston. So respiratory rate more than 22, altered mental status and systolic BP less than 100 millimeters mercury is the value for quick SOFA score. So these are all very basic questions being asked in INI Common Entrance Test. This is a pink cannula, you will be knowing this. This is a pink cannula, please don't forget, this is a pink cannula, you should not forget. So pink cannula, The size of this cannula they are asking. So you all know very well 16 gauge cannula, 18 gauge cannula we commonly use in practice. 16 gauges grey Venflan, 18 gauges green Venflan, and 20 gauges 20 gauge Venflan is pink Venflan, which is also used in adults. So please don't forget this is a pink Venflan, 20 gauge used in adult. So please don't forget 20 gauge is pink Venflan, 18 gauge is green, 16 gauge is grey. These are very commonly asked MCQs, and yellow is used in newborn, which is 24 gauge. Yellow is to newborn, which is 24 gauge. So again, these are all very basic questions which are asked in INI common interest. Again, name this position of the patient in operation theatre. You can see the patient head end is up, the foot end is down. So this is a position classically done to reduce the edema in the neck or dilatation of the veins in the neck while we are operating here. So this position is known as reverse Trendelenburg position. Okay, this position is known as reverse Trendelenburg position. This is known as reverse Trendelenburg position. What we are seeing is reverse Trendelenburg position in which head end is up. So please don't forget, many students will get confused with the Trendelenburg. Trendelenburg position is a leg is up, which is used for varicose vein surgery. The name of varicose vein surgery itself is Trendelenburg operation. So this is reverse Trendelenburg position, which is used for head and neck surgeries. So please don't forget this point, very important for your exams. Reverse Trendelenburg is used for head and neck surgeries like thyroid operations. Trendelenburg is used for varicose vein operations. Please don't forget, the answer here is reverse Trendelenburg. So this is a new question expected, which we already expected because of COVID. In the following conditions, sanitizer can be used. We all use sanitizer before examining the patient, after examining the patient, and even we can use after the hands are washed with the soap, we can use the sanitizer. Or you should also use when after touching the surroundings. We should not use the soiled hand. This is wrong. Cannot be used. If I am having full of blood in my hand, I cannot use a sanitizer for sterilization. I should first of all wash it with the water, dry my hand, then only I should use a sanitizer. So A, B, C is correct. Which all place we can use this? A, B, C I can use. D I should not use. When hands are soiled, I should not use. Okay, this is very simple question. So answer is 2. So this is again a very, very commonly asked repeat question. 25-year-old male patient came to emergency room with a history of trauma. Respiratory rate is 35, BP is 100/60. Percussion shows hyperresonance. This right side chest is hyperresonant. So definitely this is a pneumothorax. So definitely that's a pneumothorax, and FAST was performed in the emergency room and it is normal. Actually FAST in pneumothorax will have a finding. What finding is it? So FAST in pneumothorax will have a finding that is seashore sign, but we cannot always depend on that. Why I am not telling you should depend on this sign, seashore sign? Some books will say seashore sign is for normal lung, stratosphere sign or barcode sign is for pneumothorax. This is given in some books, but ATLS says all these signs are for pneumothorax only. ATLS manual, when you go and read, that gives seashore sign, stratosphere sign, barcode sign, everything for pneumothorax. But this is a clinical diagnosis. We should not expect to diagnose it by FAST or X-ray chest. When the history is typical and the findings are typical, you should immediately put a wide bore needle. Wide bore needle should be put in the 5th intercostal space. In mid axillary line, you should put a needle first. The needle is usually a 16 gauge needle is inserted in the 5th intercostal space, and that is an emergency procedure. We should immediately plan for ICD. We should call the surgeon to come and put an ICD as early as possible. So ICD with underwater drain. So with an underwater drain, intercostal drainage tube is an ideal procedure. So what is the next step here is wide bore needle followed by intercostal drain in the 5th intercostal space is the correct answer. Many students were arguing at that time, this is the correct answer. Wide bore needle in the 5th intercostal space is the correct answer, but that is not the final step. So there is a choice very clearly given. Wide bore needle we put a wide bore needle within 5 minutes or 10 minutes I can arrange an ICD and can put. So this is the correct answer for this is B. So this is also a direct line from Palian law. Please remember, this is a direct line from Palian law. Tension pneumothorax is a clinical diagnosis and treatment should never be delayed for waiting for radiological confirmation. Okay, please don't forget, the only line which doesn't suit in this paragraph is FAST can diagnose pneumothorax, but it is operator dependent. Maybe the operator would have missed the pneumothorax findings of stratosphere sign. So we cannot depend on that. So immediately put a needle, large bore cannula, Bailey says to put in the second intercostal space mid-clavicular line, but it is now changed to fifth intercostal space. Mid-axillary line is the correct answer now. So follow this for your exams. So the 8th question is a very straightforward question. You can see there is a single bubble appearance. Can you see that's a single bubble appearance in a newborn baby? So single bubble in a newborn baby is a classical finding of congenital hypertrophic pyloric stenosis. So please understand this is a congenital hypertrophic pyloric stenosis. So now let us see the findings. Congenital hypertrophic pyloric stenosis will have non-bilious vomiting, not a bilious vomiting. Yes, I can palpate a mass in the right hypochondrium. I can see the pyloric hypertrophied mass, and there will be hypokalemic, hypochloremic, hyponatremic, metabolic alkalosis because of constant vomiting. The baby will develop the classical finding of hyponatremic, hypochloremic, hypokalemic, metabolic alkalosis. So the answer here is B, C, D is the correct answer here. Palpable mass, metabolic alkalosis and electrolyte imbalance is classically seen. So to correct the metabolic alkalosis seen in these babies, what is the fluid of choice? This is the next expected question from this topic. In most babies, alkalosis can be corrected by giving 150 to 180 ml per kilogram per day of 0.9% saline with the ACL. Please remember the fluid of choice is 0.9% saline. NaCl is the fluid of choice. For hypokalemia, we should supplement with KCl in 5% glucose. We should not give ringer lactate. Ringer lactate can aggravate the acidosis, which is happening paradoxical renal aciduria. No? So that such thing can happen if you give ringer lactate. So ringer lactate should not be used. The fluid of choice is NaCl. 0.9% normal saline is the fluid of choice, and the fluid correction may take around hypochloremic, hypokalemic alkalosis can be corrected. This may take 48 hours if the chloride is 85 millimoles per liter or lower. This is directly from Bailey law. Please don't forget it is common in male babies, and they will be having severe hungry. They will not have a loss of appetite. They will be having severe hungry. They will be seen commonly between 2 to 8 weeks. So please don't forget, this is very important topic. Congenital hypertrophic pyloric stenosis. We should do a Ramstad's pyloromyotomy. So Ramstad's pyloromyotomy is done, and feeding can be started in 6 hours. If everything goes well, we can even start feeding the baby in 6 hours. If there is a mucosa opened, in such cases we should delay the feeding for 48 hours. If no mucosa is opened, we can start the feeding in 6 hours time itself. Please don't forget, okay. So this is a classical question from Sabiston. So this is a question asking which is the following used for arresting variceal bleed in portal hypertension. So we have shown many tubes here. Please see the first tube. The first tube is having 3 lumens. This is an old type of tube known as old Sengstaken-Blackmore tube. Old Sengstaken-Blackmore tube which had only 3 lumens. One is to inflate the gastric balloon, one to inflate the esophageal balloon, and one to aspirate the stomach. So the new balloon is having 4 lumens which will have an additional aspiration of esophagus also. Aspiration of esophagus is also seen. This is called as modified Sengstaken-Blackmore tube. Actual name of modified Sengstaken-Blackmore tube is known as Minnesota tube. Minnesota tube or modified Sengstaken-Blackmore tube is commonly available tube now. So in practice, we are using this tube to arrest the bleeding from esophageal varices by tamponade effect. So see this picture. First picture is showing you an upper GI scopy. Upper GI scopy will be used to stop the bleeding by endoscopic. We can use sclerosants. To inject endoscopic sclerosants can be injected to arrest the bleeding. So this can also be used. And this picture is showing you a variceal band ligator. This is a picture showing you variceal band. Endoscopically, we can also put a variceal band ligator is also shown in the 4th picture. So the answer for this question is all the things can be used in variceal bleeding. A, B, C, D is the answer for the 9th question. Please don't forget. So image A is an old Sengstaken-Blackmore tube. B is modified Sengstaken tube, also known as Minnesota tube. Image C for sclerosant. Image D for band application. Okay. Since it's a last minute revision, I don't want to waste much time in discussion. I want you to go up to the exam catching the essential core points for the exam. So that's why I'm discussing little speed. I am hoping the students who are attending the class have already completed all the preparation and ready for exam. So I wanted to give a fast review of this session. So match the following. So A is an endotracheal tube, B is a Ryle's tube, C you can see an underwater drain. There is a mark there which is an underwater drain. You can see we have to put the water up to this place. In the case of pneumothorax, we use this underwater drain, and this is urinary bag. So these are the points you should not forget. So 1, 2, 3, 4, A, B, C, D, it's directly matched. So the answer is ET tube for A, Ryle's tube for B, underwater drain for C, and urine bag for D. So next question is a very commonly asked urology question. A girl presents with continuous dribbling of urine. So she is having continuous dribbling of urine. See, please understand the history. She is having continuous dribbling of urine from the vaginal area. She is also having fullness of bladder. She could also pass urine in between. That means her bladder is getting filled. That bladder is getting filled from the ureters. Apart from that, she is having a continuous dribbling in the vagina, means there is a ectopic ureter connected to the urethra like this. There will be an ectopic ureter connected to the urethra like this. So this is a typical case of ectopic ureter. So very common in females. Ectopic ureter is very common in females, and they follow a rule known as Weigert-Mayer rule. So the ectopic ureter Weigert-Mayer rule is the ectopic ureter arises from upper pole, runs medially, and joins distally the urethra. It joins the urethra distal to the external urethral sphincter. This is external urethral sphincter. It joins distal to the external urethral sphincter. That is why there is a dribbling of urine. If this case is seen in boys there will be no such dribbling because it joins in prostatic urethra. In boys it joins in prostatic urethra proximal to external urethral meatus. So boys will not have incontinence, they will only have UTI, whereas girls will have paradoxical urinary incontinence. We call it as dribbling. Paradoxical urinary incontinence, we call it as dribbling. So the answer here is C. So C, ectopic ureter is common in females. 1:1 ratio is there. So in this you can see the ectopic ureter opens either into the urethra below the sphincter or into the vagina itself it can go and open. Therefore there will be dribbling known as paradoxical urinary incontinence. In males they will be having a continence. Normal continence is seen in males. So 100 times asked question. From the X-ray itself you can see there is an air under diaphragm. So it is a perforation. It is a case of perforation peritonitis. So 35-year-old male presented with a peptic ulcer disease came with a pain abdomen for 2 days duration and obstipation for 2 days. Pain abdomen and obstipation for 2 days. X-ray erect abdomen was done. What is the next line of management in this patient? So patient is having pain abdomen and obstipation. He is having X-ray abdomen was done, and the next line of management, what is it? So patient with the perforation, the next line of management is IV fluids and laparotomy. That is a classical point. No need of ultrasound abdomen. X-ray itself is enough. X-ray is enough. In X-ray itself, 70% cases of perforation can be diagnosed like this. So the answer here is B and C. Keep the patient in observation is the most worst treatment. You should never manage them conservatively. You should shift them to operation as early as possible. So it's a case of duodenal ulcer perforation. For perforations less than 1 centimeter, you can directly close and buttress with the omentum. So if the hole is this like this, you close the perforation and put the omentum like over the closure. In 1 to 3 centimeter is what we use as the omentum is kept on the hole, and we have to take sutures including the omentum like this. So that is Graham's omental patch closure. For 1 to 3 centimeter, we do that technique which is commonly done. And for more than 3 centimeter, we should do a pyloric exclusion. What is this pyloric exclusion? So if you see this, a duodenum is having a perforation like this, very big centimeter, 3 centimeter or more perforation. If you try to close, it can leak. So what will I do now is, I will do a pyloric exclusion. I will close this pylorus. Pylorus closed. Pylorus is closed, and I will bring the jejunum and do the gastrojejunostomy. Pylorus is usually closed with a catgut or vicryl. It is GJ done for the foot to go down like this. And if omentum is not available, we will bring the serosa of the jejunum like this and close this defect with the jejunal serosal patch. Jejunal serosal patch is used. This is for more than 3 centimeter. This procedure is mentioned in Sabiston. Pyloric exclusion with Roux and Y limb jejunal serosal patch. So I have not drawn a Roux and Y, but we can make a Roux and Y type limb also. But point for your exam is jejunal serosal patch is needed if omentum is unhealthy, and also perform GJ. Slowly what will happen? This absorbable suture material will disappear and you can see the food particles will start moving like this in future. In future, it will start moving down the duodenum. So this is the most controversial question every time. 40-year-old female patient underwent cholecystectomy. Post-op, she has complaining of pain abdomen. So you have to now rule out, identify the bile leak. So bile leak can be diagnosed by the following investigation. It can diagnosed by HIDA scan, it can be diagnosed by ERCP, it can be diagnosed by CT abdomen, except MRCP, all the other three can be used. Very interesting point is that. So which is best among the three? HIDA scan can diagnose, ERCP can diagnose, CT can diagnose. Which is the best? So which test is performed? Everything can be performed. Best in terms is ERCP because it can diagnose the leak, it can identify the site of leak, and it can treat the leak by stenting. So therefore, ERCP is the best among these three. I'll ask you to go to ERCP. Okay. So ERCP is better than CT abdomen. But the point is, Sebastian directly gives one interesting line. Please read this line. If bile duct injury is suspected, CT scan should be performed which shows ascites or right upper abdomen quadrant collection with bilioma. Immediately we should put a PCD and electively ERCP is done to know the site and patterns of injury. So ERCP is not an emergency. Please remember, if the question was like this, which test is performed to identify immediate next investigation to be done is usually ultrasound or CT abdomen. That is the immediate next investigation done, but they didn't ask like that. They didn't ask even the best investigation. So best is ERCP, immediate next is ultrasound followed by CT abdomen. So CT abdomen is much better than ultrasound to identify the collection, and under ultrasound or CT guidance we can put a percutaneous drainage. Okay. So the Bailey very clearly says HIDA scan is helpful and can confirm the presence of leak. It can be used to identify and quantitate the leak, but HIDA scan cannot identify the location of leak. If available, ERCP should be considered because this is both diagnostic and potentially therapeutic. So I feel ERCP should be the best answer here. MRCP is also helpful in determining the level and degree of injury, but not commonly used. It is not useful to know the location of injury. So MRCP we are not using to identify the leak, biliary leak, but it can identify the injury and in later places to identify the strictures. The bile duct injury can future form strictures, and for strictures gold standard is MRCP. So biliary system and all, you should be very clear with each and every MCQs. So the next best investigation is ultrasound or CT scan. ERCP is the gold standard. For biliary strictures, MRCP is the gold standard. For post-op bile duct injury forming strictures, MRCP is gold standard. Okay. What is the additional benefit of doing E-fast? I hope you will be knowing this is the original fast which was done for years together. We will focus on the liver, we will focus on the spleen, we will focus at the epigastric region, we will focus at the pelvic region. So this is what we do routinely in a normal ERCP. 4 regions are focused: liver, spleen, epigastric region and pelvis. In liver we keep a longitudinal view, in spleen we keep a longitudinal view, in epigastric region we should keep a transverse mode, and pelvis, both modes are kept. This is a normal fast. E-fast is extended towards the right side chest and the left side chest. E-fast is extended to examine the right side chest and left side chest for pneumothorax. For hemothorax, all these cases can be diagnosed with the help of E-fast. So chest trauma can be identified is the correct answer for 14th question. Okay, please don't forget, pneumothorax will show you stratosphere or barcode sign. So 15th question is 100 times asked repeat question. What is the most common retroperitoneal tumor? So most common tumor seen in the retroperitoneal region is liposarcoma is the most common retroperitoneal tumor. So please don't forget it. The most common organ compressed is ureter. Such huge tumors can compress the ureter. So please don't forget this is direct paragraph from Sebastian. Approximately 15% of the soft tissue sarcomas arise in the retroperitoneum. In this location, the most common histological type is liposarcoma followed by leiomyosarcoma. Abdominal pain is present in 50% of the patients, and other symptoms include nausea, vomiting, constipation, weight loss. Lower limb edema can happen due to compression of the vessels. So due to nerve compression, lower limb paresthesia and paresis can be seen. Gold standard investigation is CT abdomen, and that will show you variable fat density. And please don't forget retroperitoneal sarcomas, no need of image guide biopsy. You should not do a biopsy in fact. It will disseminate the tumor intra-abdominally. So you should do a CT scan only. So this is again 100 times asked MCQ. 40 years male known case of varicose veins. On examination is having eczema and lipodermatosclerosis found. What comes under the CEAP classification? This is C4 under CEAP classification. C1 is nothing but telangiectasia and reticular veins. Please don't forget, this is from Bailey. C1 is telangiectasia, means less than 1 mm vein. Reticular vein is 1 to 3 mm vein. Varicose vein is more than 3 mm size diameter of the vein. The vein diameter is more than 3 mm is varicose vein. If only edema is there, it is 3. 3 for edema, 4 for pigmentation and eczema. 4A is for pigmentation and eczema, B for lipodermatosclerosis. So please don't forget this question, lipodermatosclerosis is very commonly asked, it is C4B. Okay. 5 is healed ulcer, 6 is active ulcer, active venous ulcer on the medial malleolus, we call it as C6. So this is a C4 case of lipodermatosclerosis, so I will go for C4B. Only eczema, it is C4A, lipodermatosclerosis is C4B. Next question, 45-year-old female patient, on examination of her breast, 4.5 into 3 centimeter irregular mass is present in the left upper quadrant of the right breast over here. There is a mass which is not fixed to the pectoralis major. No skin change is also seen. So it is having a single node which is 2 into 1.5 centimeter. So what is the staging for this case? So T2 is 2 to 5 centimeter size. Single or mobile axillary node is N1. So this is T2N1, which is nothing but early breast cancer. So no mass felt in the opposite breast. What are the investigations you do for this case? So you should understand, first of all, you should know the staging. The staging based, we should know early breast cancer, locally advanced breast cancer and metastatic cancer. So this is a picture of early breast cancer. Early breast cancer, please remember, PET scan is not needed for a early breast cancer. PET scan is a costly investigation usually advised for locally advanced breast cancer only. No need to do PET scan for early cases. Early breast cancer, there is no advice of doing a PET scan. And when there is a node enlarged, clinically palpable node, no need to go and do a biopsy to confirm the node. Unless otherwise proved, it is a metastatic node only. If you have a node in the axilla, unless proved otherwise, and that too in this size, it is always a metastatic node only, you should go for a axillary dissection. Axillary dissection should be done for this case. So the answer here is mammography will be done for opposite breast and for the same breast also to look for multicentricity, and biopsy of the breast mass by using true cut biopsy needle should be done. So the answer here is 2 investigations are done, A and C only, not needed other things. Okay, please understand this is a very clear cut early breast cancer. Bile leak from an aberrant right hepatic duct that is not communicating with the common duct. So please understand, this is a classification known as Strasberg classification. It is of 5 types of Strasberg classification are seen. Let me show you. The first type is most common. This is A. This is a cystic duct. We have put a clip that has fallen down and it is leaking. That is cystic duct blowout. Cystic duct blowout is type A injury. Okay. Type B is an injury of this aberrant duct. This is an aberrant right posterior sectoral duct. If I put a clip for this duct, aberrant duct, if I put a clip, that is B type. If I cut this duct and there is a leak, that is C type. So aberrant duct is cut and there is a bile leak, it is type C. Okay, aberrant duct is cut and it is leaking is type C. And type D, there is a lateral injury of bile duct. Lateral injury is type D. Circumferential injury is type E. This is a paragraph directly from Bailey and Love. Please don't forget, the most common is type A. So this is based on Strasberg classification. You can see aberrant duct injury is type C. Aberrant duct clipping is type B. Lateral injury is type D. If I cut it circumferentially like this, it is type D. So circumferential bile leak from the main duct without major tissue loss. So there are many subtypes. from this. I am not going into that. So, Strasbourg classification, type E is circumferential injury. It is further divided into many types with the injury more than 2 centimeter, less than 2 centimeter, at the level of confluence, separated like that. So, there is a classification, but this is not asked in the exam, so I am not going into that. But please don't forget Strasbourg A, B, C, D, E. 40-year-old female patient has a massive enlargement of her left breast for 30 days. It is mobile over the chest wall and there is a local temperature is increased. What is your likely diagnosis? So, patient is having a rapid enlargement in 30 days and there is a mobile, there is a local rise of temperature. It is more in suggestive of inflammatory breast cancer from the image. It's an image based question. It is more of inflammatory breast cancer. We call the staging as T4D. So, T4D inflammatory breast cancer. There will be erythema, edema and warmth of the breast. This is from Bailey and Love. It is 1 to 5% of all breast tumors, most aggressive subtype. So, there will be pure orange will be seen, there will be rapid onset of disease. The pathological hallmark of this case is presence of tumor cells within dermal lymphatics. There will be presence of tumor cells within the dermal lymphatics is a classical diagnostic thing. Axillary node mets are there and there is a very poor prognosis in these type of cases because they progress over weeks to 3 months. There will be rapidly enlarging tumor. Okay. So, young male with a head injury was brought to emergency in an unconscious state. Patient was not able to breathe properly but put on ventilator support. GCS was only 88 and is having findings of raised intracranial pressure. NEECT and spinal imaging were normal. So, whenever you see a patient with a head injury and non-contrast CT scan of brain is normal, you should think of DAI, diffuse axonal injury. MRI is the investigation of choice for this. For diffuse axonal injury, CT scan cannot diagnose the finding. It is diagnosed by MRI. This is a form of primary brain injury seen in high energy accidents which usually renders the patient comatose. Severe acceleration, deceleration movement of the brain causes damage of the neurons and there will be post-mortem finding will be hemorrhagic foci in the corpus callosum and dorsolateral rostral brain on CT. So, but CT may be often normal. Please remember, CT scan may be often normal. It is most of the time diagnosed in a pathological diagnosis in the post-mortem only. So, CT normal, head injury, think of diffuse axonal injury. So, this is a new question. Actually, this is the only new question which was asked in INI. So far, whatever I have discussed, no 20 questions. All the 20 questions have been asked here and there as a repeat question. Most of them are directly discussed in our videos, in our surgery 6 videos. We have completely discussed them. In DocTutorials also, we have discussed this completely. So, it is a clear-cut question. Only new question is this. As per European Hernia Society classification, incisional hernia at the level of umbilicus is given the term M3. So, this is a classification I want you to remember. European Hernia Society classification of incisional hernia. Please remember, subxiphoidal is, if there is a hernia, it is M1, epigastric M2, umbilical M3, infraumbilical M4, suprapubic M5. So, please remember this 5. This is a new question asked from European Hernia Society classification. It is M3 is umbilical, M2 is epigastric, M4 is infraumbilical, M5 is suprapubic incisional hernia and M1 is subxiphoidal incisional hernia. So, similarly, depending upon the defect and there are many other classifications, but the question asked in this is European Hernia Society. Please understand this M1, M2, M3, M4, M5. So, and this is again a repeat MCQ regarding the boundaries of laparoscopic anatomy of inguinal hernia. I hope you know the anatomy of inguinal hernia. I am drawing the anatomy now. This is a iliopubic tract. This is deep ring. This is gonadal vessels. Testicular artery and testicular vein is entering and this is vas deferens and this is the reflected part of peritoneum. So, you can see this is triangle of doom, this is triangle of pain, triangle of doom bounded by deep ring, vas, gonadal vessels, triangle of pain bounded by gonadal vessels, iliopubic tract, reflected peritoneum as a third boundary. So, this is a very clear-cut question repeatedly asked. In this triangle of doom, you have external iliac artery and external iliac vein. And in this triangle of pain, we have all the important nerves. The most common nerve to get injured is lateral cutaneous nerve during laparoscopic hernia repair. So this question, first 2 points, please understand. Medial boundary of triangle of doom is vas deferens, true. Triangle of doom medial boundary is vas deferens. Lateral boundary of triangle of pain is iliopubic tract. You can see this is a lateral boundary of pain, iliopubic tract, medial boundary is vas deferens. So myopectineal orifice bounded by iliopubic tract inferiorly is wrong. It is not bounded by iliopubic tract. I will show you the boundaries of myopectineal orifice of Fruchert. It is bounded medially by rectus abdominis muscle. This is rectus abdominis muscle. Laterally by iliopsoas muscle. Superiorly by conjoint tendon. You can see the conjoint tendon. Inferiorly by the bone pecten pubis. So what is the importance of this orifice? The importance of this orifice is, in case of hernia repair, we keep a huge mesh like this much size, closing this myopectineal orifice of Fruchert only, we close this. So myopectineal orifice of Fruchert is the anatomy we are closing, anatomical defect which we are closing, bounded by rectus, iliopsoas, conjoint tendon and pecten pubis. So please don't forget this question of myopectineal orifice bounded by internal oblique and transverse abdominis, nothing but conjoint tendon superiorly. Iliopubic tract is not a boundary for myopectineal orifice at all. So this is not a new question, this is also an old question only. 10 years old girl presented with a growing left-sided neck swelling. Swelling is firm and non-tender. She has freckles and flat spots, so macules. So she is having macules and axillary freckles. Probably she will be also having capsulite spots. I couldn't get that image. So this is a case of von Recklinghausen's disease. Von Recklinghausen disease, which is nothing but neural tumor which is seen in the neck. So answer here is straightforward, neural tumor. Neural fibromatosis 1 is a commoner variant. It arises from chromosome 17 mutation. There will be capsulite spots, more than 5 smooth surfaced capillate spots will be there, nodules will be there, freckling will be there. All these things I hope you will be knowing from medicine. So this is a very simple question again. Match the following nerves injured. External laryngeal nerve is injured in a thyroidectomy. The most common nerve injured is external laryngeal nerve. Long thoracic nerve of bell is injured in mastectomy. So long thoracic nerve is injured in modified radical mastectomy. Hypoglossal nerve injured in submandibular gland excision. Phrenic nerve is injured in thymectomy surgery. Thymectomy surgery. So this is answer here. So please remember 1D, 2C, 3B, 4A. So this is a very simple undergraduate level question. You should not make mistake in this question. Okay. So long thoracic nerve bell in MRM, which causes winking scapula, external laryngeal nerve in thyroidectomy, phrenic nerve in thymectomy, lingual and hypoglossal nerves in submandibular gland excision are the nerves injured. 40 years old patient with previous history of myocardial infarction presented to emergency with a history of multiple episodes of vomiting, pain, abdomen and blood and stools. So a case of MI presenting with the blood and stools. So BP is low, pulse rate is increased, pulse were irregular, so probably she is also having atrial fibrillation. Abdomen was soft and non-distended, bowel sounds were absent. So this is a case of, typical case of mesenteric ischemia. The bowel has gone for gangrene due to a thrombus or due to embolus. So this case is acute. So acute cases are usually due to embolus arising from the heart, which has gone and occluded the vessel that has resulted in the bowel gangrene. So this is a classical question already discussed in our classes. In acute mesenteric ischemia, there will be gangrene of bowel with absent bowel sounds and soft abdomen, and the signs will be out of proportion to the symptoms on examination. Okay. So this is a classical trophic ulcer. You can see this is a trophic ulcer you are seeing in the image. It is due to neuropathy cause. It is a combination of causes, neuropathy, vascular, together along with the diabetes can cause this trophic ulcer. So in these ulcers, therefore, peripheral neuropathy will be seen, distal pulses may not be palpated, restriction in movements of toes may be seen, diabetes mellitus is associated. So I will go for all the following 4 are seen. This is a picture of trophic ulcer due to neuropathy and vasculopathy. So the causes are diabetes, leprosy, peripheral vascular disease, etc. Because of absence of pain and excess pressure results in this type of ulcer. Secondary infection can also happen. These type of ulcer will not heal by regular dressing. We may need to put a flap with the help of plastic surgeons. Okay. 35-year-old male, chronic smoker. So please understand the history. Smoker, 35-year-old male with the right calf pain and ulcer over the great toe with surrounding black pigmentation. What is the next investigation you should do? So this patient looks like an atherosclerotic disease, or he may even be a thromboangiitis obliterans. Let us assume the common disease, atherosclerotic disease with a gangrene of the limb. So which is the next investigation? The question is asking next, not the best. If they ask me the best, I would have gone for digital subtraction angiography. The next will be always a non-invasive one, that is duplex scan of lower limbs. Okay, so they are asking you next investigation. Next is duplex. Best or investigation of choice is digital subtraction angiography. This is also a direct paragraph from Bailey and Love. Please don't forget this line. So these are all medicine questions actually. 25-year-old female with a rapid weight gain and loss of appetite. Patient has a low T4, high TSH. So the patient is having hypothyroidism. So hypothyroidism due to Hashimoto's thyroiditis. I'll tell you, this is the most easiest paper in the past 5 years of Aiims exam. So I have not seen such a easy paper for Aiims exam. Probably after combining the institute exam papers, all the 30 questions are very easy except that one question which is a new question. Otherwise, all these questions are being repeated. Okay, Hashimoto's thyroiditis. In a patient, metastasis was found in the liver. On biopsy, it was found to be adenocarcinoma. Cytokeratin 20 positive and cytokeratin 7 negative. This primary is most likely from. So this is a pathology question actually, not a surgery question. CK20 positive, CK7 negative. So this is very classical of colon cancers. So CK20 positive is for colorectal origin. CK7 positive is 7 is for many other tumors, lung, breast, thyroid, pancreas, female, etc. So most easy to diagnose whether it is from colorectal, it is by measuring CK20 from the biopsy tissue. Biopsy positive from the biopsy tissue. So this is a pathology question actually, it's a pathology repeat question, though it is not a surgery question. For completion sake, I have put the question. This is also another pathology question. Which of the following is correct about Peutz-Jeghers syndrome? Congenital hypertrophy of retinal pigment epithelium. Absolutely wrong. You all know very well, congenital hypertrophy of retinal pigment epithelium is seen in familial adenomatous polyposis. So there will be arborizing pattern seen in the mucosa. That is true. It looks like a tree. Arborizing means the mucosa looks like a tree pattern. It is seen. Yes, true. STK11 mutation. Autosomal recessive is wrong. It is dominant. There will be multiple GI polyps seen, most common in jejunum. So most common in jejunum, otherwise it can be seen anywhere in the GIT. So the answer is 2, 3 and 5 are the correct answers for this. You can see the arborizing pattern like a tree. That is a hallmark is arborizing pattern. The smooth muscle fibers are arranged in an arborizing pattern. It is a typical of Peutz-Jeghers polyp. It is autosomal dominant. There is 39% risk of colorectal cancers. Mucocutaneous pigmentation is seen. Chirpy is for FAP. Congenital hypertrophic retinal pigment epithelium is for FAP. Most common site of polyps is small bowel in jejunum. It is due to STK11 mutation with the chromosome 19p. Please don't forget that histologically there is an interesting point. Peutz-Jeghers differs from juvenile polyps histologically as PJS polyps are due to overgrowth of muscularis mucosa rather than lamina propria. The overgrowth of muscularis mucosa is seen in PJS. Lamina propria is seen in JPS. This question, this line is from Sebastian, may be asked in your exam, just have in your mind. So Peutz-Jeghers will have a muscularis mucosa hypertrophy. Lamina propria hypertrophy is seen in juvenile polyposis syndrome. So that completes the discussion.